Yeah, okay. Is your mic working? Yeah, we're going to get started. And maybe since this is a fireside chat, can I ask some of you to come over here, because fireside can't be sitting so far away, right? Some of our people here, yeah. Yeah, come, Professor Joseph, yeah, thank you. Yeah, yeah. Can I just ask some of you to be here so it's a little bit easier, a bit more intimate, essentially. Right. Okay, we're going to get started, so maybe I'll just set a little bit of tone, because I know that we didn't get Joseph, Haotian, and Robert much preparation, nothing to be prepared about, just a fireside chat. And what we're going to do today is maybe cover several aspects, and I'm going to get a little bit of maybe introduction from the three of you on what you're doing and what you think are the current things you're thinking about and something in the future. Then we go into some topics that would be of relevance, and then we, of course, open up to the floor, right? And, of course, we are covering this big topic about AI, and I will put it as medicine and healthcare first, and ophthalmology as an example second. So Joseph can give us a little bit more, and then I think, but Haotian, you're also doing something bigger, right? Then I will go into some things about differences, particularly, right, from your experience in Singapore now, and then Haotian in the China system, and then maybe Robert on the US system. So priorities and directions. And then we'll talk something about, I would say, challenges, right? You know, that the pain points that we are all facing, and we can cover, since we are all at different viewpoints, a bit from the academic side, from the industry side, our interactions with industry, because there might be some industry people, and that will cover big tech as well, right? The big techs of the OpenAI and so forth, and China has several of those. And then a little bit about policy side, which I think Joseph has. So I will guide some of these questions, and then we can have questions from the floor. I think from the floor, what I gather from talking to some of the younger people here is something about careers. So I've spoken to some young people. Some of them finish medical school, where they're going to go next. Some are in the medical field, some are in the engineering field, and it's a very exciting area. And some people say, should I do my clinical training, or should I do a PhD? So we hear a little bit of guidance from you. So, and then we can, of course, talk quite broadly, essentially. All right, so I hope all of you prepare some questions. They are very senior and give you a little bit of guidance over what I think is an exciting field, but lots of questions more than answers. So maybe we can have Joseph, just a short, whatever you want to say, introduction, what you're doing on, what you think is important, and then we get Haotian and Robert. Yeah, Joseph, thank you.
Great, thank you. Some of you may know that I moved from Hong Kong to Singapore 4 years ago. What attracted me to go to Singapore at that time is that there is a new medical school inside a big university with very strong engineering college. And I think there are two things which attract me. One is a big engineering college with AI, robotics, and so on, which gives me a lot of opportunity to really work with technology and engineers. And the young medical school is probably more easy to go into innovation, to do something different, to mold a medical school. So I was carrying this hope from Hong Kong to Singapore to see whether, well, if I have 10 more years in my career, I'd like to see some contributions bringing technology into daily practice. And in fact, Singapore is a very good place for this, because the government is pushing very strongly into making Singapore a smart city, a smart nation, and a smart airport, smart transportation. Everything is very smart. All right. So I think this trend is basically a tsunami and covering every field in medicine. Just that we have not seen perfect performance of AI. We are still seeing, there is a little bit of distance between human diagnosis, perhaps, with AI diagnosis. We are still seeing some lack of evidence in producing AI treated patients, giving very good results. But I think let's be fair that nothing is perfect on day one. Even when the technology is very advanced, we will not be 100% accurate. We will not be 100% most sensitive and update and so on. And even human doctors are far from perfect. All right, we know that in some of the diagnoses, if we can 60–70% correct, it's quite good. So I think while we are introducing this, while we are trying to implement technology into medicine, we have to be fair, and we have to have some patience that technology continue to improve. But the big question is, how do we take technology and human clinical practice together and build a team, just as I mentioned yesterday, and maybe we'll elaborate on that later.
Okay, I think, thanks very much, Joseph. I think a lot of follow-up questions for you, building teams, and engineering school doing medicine, which I want to compare. And I also want you to maybe highlight a little bit difference between moving from Hong Kong to Singapore. Are there differences in thoughts about AI and so forth, essentially? So a few follow-up questions which I will go into. But let's go with Haotian. I mean, you are one of the youngest Yuan Zhang and hot onto AI even before it was there. I mean, what are your thoughts and what are you working on? What's the direction from your side? Yeah.
Okay, thanks. Yeah, I think it's really my great honor to have this fireside chat. Just first, we just meet yesterday, but Tim Wong and Michael, we are old friends, and I think my share my I think from three sides. The first is before this fireside, we talked the keywords new generation. Yeah, you have mentioned, Timo have mentioned, maybe half years ago, I'm the youngest president in Chinese hospital, big hospital, but now it's not the youngest. But I think I'm one of the new generation. And what new generation means, you know that Timo is also good friends of my teacher, Professor Liu Yizhi. Yeah, because Zhongshan Obstetric Center, till next year we are the 60th anniversary, and everyone knows the 60 years is not a short time, but also not a very long time. But I think for this 60 years, we have many generations. And to me, the new generation, I should consider what is my advantages and what can I do. I think the most important thing is the direction, what we are doing. And I remember from maybe 10 years ago, Professor Liu and my other senior colleagues asked me to think about these things. What is your advantage for this new generation? And at that time, I'm thinking, because maybe the audience are more younger than me, younger generation. But for me, I think what is my advantage is we can have the computer, digitalization is our advantages. And we should do this with the traditional medicine. So I think young generation is young technology. This is one of things I want to share. The second is, actually, I think Timo is also the young generation in China. Oh, because you moved from Singapore to China, and I think the development of China need this kind of young generation, more international, and can more in different culture from the world to come to China to develop the new technology, new model to serve the health of more and more people together. And actually, China has some advantages for the maybe industry and the whole system. I think have some advantages, but also we have to do many things to improve all the system also. And so I think for For us, included, I think we sit here, what we can do is really to work more closely together. And especially, I think this APTOS, I think this kinds of society chat, I think is lecture is very good for us to have this opportunity to do things to get more collaboration.
Okay, thank you very much. I think a lot of good points which I'll also ask you to elaborate a little bit on. New generation, very key word, right?
Yeah.
What does that mean? The new generation, Yuan Zhang in China, quite new essentially, right?
Yeah.
So what does new mean? And some advice for some of the younger people, how do they go into this new generation? I'll ask you to later on elaborate a
thank
little
you.
bit. Technology as a center.
Yeah.
Now maybe we go to Robert and maybe give us a little bit of scene, from us kind of like in Hong Kong, in China, what's happening in the US and what you're observing from the epicenter of technology in Stanford, essentially, right?
Yeah, thank you. I think I'll give you a brief context. So I'm a practicing ophthalmologist. I specialize in cataract and glaucoma surgery. And I spend most of my time as a clinician. So see patients and do surgery at least 4 days a week. So although I'm academic, I'm very close to new technologies like which surgery to do, new diagnostic tools, how can we use it to do our job better, and study these things. So I'm very close to what I think is most important, which is the downstream, where this is really cool technology, foundational models, but where is it actually going to help us? What kind of pain points do they actually have? What do they really want? Do they want some model that says 80% sensitive specific to diagnose glaucoma? Is that something they really need, given all the other tools they have or how the system works? So what is it that the doctors really want? And then what does the patient really want? Do they want AI to, assist in their differential and diagnosis? Do they care about that? So that's kind of where I come from. There's a really amazing technology out there, right? The whole field of AI has experienced tremendous breakthroughs, but are we applying it in the right ways as academics? We study things, we look at what regulation says, we try to think what people want, but if you aren't actually very close to the patients, maybe what they really want is just access to their doctor. They don't care if there's an AI model that performs as good or better than the doctor. They just want to talk to their doctor. And we want to push a chatbot to talk to them. Is that right? I mean, this is what I think about, being in the epicenter of technology, the end stream last mile user. So implementation, what are the barriers? Why? Why would a hospital want to do something versus what the chair wants versus what I want? And these are all play a factor in how well the new technology actually reaches and solves people's problems. So that's one aspect. And I think the other factor that maybe is slightly different in US culture, like the Silicon Valley, is that we're okay with trying things and finding out that it doesn't work. Like, we're good at saying, today I'm gonna see what happens here, I'm gonna try it out. And if I fail, that's not a black mark on my record. It's actually a badge of honor. And sometimes in the culture of educational system here, you're always trying to strive for the right answer, the best result, got to score perfect on everything. It's a very atmosphere that lends itself difficult to go against what everyone else is doing. So one thing I would want you to take away is, just don't use AI in the same way everyone else is using AI. Why do you have to use it for screening? Or, yeah, good for community health. Maybe that's a good option. We use autonomous DR screening already at Stanford, 7 sites. The utilization, maybe 10% of the population is using it in endocrine and PCP. Why not more? It's available, it works well, it's paid for. There's liability things that they already figured out, yet it hasn't taken off. So these are the kind of things that I would want all of you to question. If you're gonna deploy something, make sure that it achieves the objectives and that aligns with what everybody wants. Because I think what a country level healthcare wants versus what an individual wants. It's like a two-tier system. You got the ability to take care of many patients for low cost, and then you've got that one patient who says, I want to pay everything to get any care I can to get best top of the line, but you can't scale that to everybody. So that dichotomy is something that is gripping our country right now, because you can see even in the social media unrest after being upset about the profits of insurance companies and pushing business. Healthcare became huge business in the US, especially because of how much of the GDP it takes up. I mean, these companies are extracting money from the government left and right in various different ways, milking the system, and that made a lot of people upset. So we need to think about, how do we use our data? How's our analytics going to be worked to actually get what we really need to get out? We spend a lot of money, and the life expectancy is not going up in America. So there's some problem there. And so these are the kind of things that hopefully you'll think differently after hearing me talk.
Okay, thanks very much. I think a lot to digest, and maybe I'll ask you to expand a little bit, and I kind of summarize a little bit here. I think putting a lot of human touch, being a clinician into the AI is quite important. Robert mentioned about really always looking at asking questions about what AI is supposed to be doing, and don't have paradigms that are fixed, keep asking. I hear a little bit about failure, and I would like to talk to you about this, because this culture is acceptable in Silicon Valley, right? It's almost a badge of honor, right? This is the Silicon Valley, Stanford kind of culture. Fail and fail again type of culture, and maybe hear a bit about you, because we have a lot of fear about failure, right? In China or in Singapore, you have one chance, you don't make it, what are you going to do next? Then I also want to maybe later on go on to this whole industry thing about profits, insurance company and so forth, so something to think about. So maybe I'll go back to Joseph and ask you to expand on some of the initial thoughts that you mentioned. Again, coming from CUHK in Hong Kong and Singapore, in this new AI era, I mean, what are the positives that maybe systems in China or even in other places could learn from, because you are seeing different systems and now going into a school that's building medicine from an engineering perspective. Joseph, yeah.
Well, if I try to compare Singapore with Hong Kong, I have to be very careful with what I say now. All right. I think it is very different in the sense that Singaporeans are very compliant to the government, to the policies. Yeah, and they trust the government very, very well. Okay, I remember during the COVID time when the government say wear a mask and everybody wear a mask, and the next day said don't wear a mask and everybody take off the mask. It may not be the same in Hong Kong. All right, sometimes it's just the opposite. So I think that's part of the culture. But in order for a patient or the public comply to AI-assisted medicine, we have to do a few things. Number one, to engage them early. All right. So in the early training and educations, and even to the public, we need to tell them what are the pros and cons, and what are the capabilities, what are the pitfalls of using AI. Engage people early. That's very important. And I think secondly, we need to, start from something which is relatively safe, but obviously produce good results that people feel that it is valuable. Let me take an example. If we start with something very sophisticated or very complicated eye surgery as the first trial of AI applied in ophthalmology, we have a chance of failing, and we have a chance of losing people's trust and faith in this. But if we start from something relatively simple and safe, say summarizing the history from the patient, after you have a dialogue in your consultation, things automatically summarize and come up with some highlight point, all right? Or when you discharge a patient, just hit a button, everything in the discharge summary will be done automatically. This is quite safe. I mean, you won't get, okay, you may get something missing and something wrong, but you won't kill anybody, right? So, but people feel that, wow, I used to spend half an hour, 1 hour to do this report. Now, just hitting one button. I think we have to build up the trust step by step. So I did a study comparing gastroenterologists. I'm a gastroenterologist. Okay, we use it for colonoscopy, decide on whether or not we find the polyp, whether this polyp is benign or not, and whether the polyp should be removed or not. We can see that the more invasive procedure, the more difficult you'll get the trust from the patients. It is independent of gender. It is even independent of the age or whether it is a private doctor or public doctor and so on. But what is important is that if we jump first to the very invasive or aggressive approach, that is, tell me whether I need to remove this polyp. Okay, a lot of people will be a little bit skeptical. What if I miss 1 out of 1,000 malignant polyp? Then I will be in trouble. But if you just start with something like automatically generated report, commenting on bowel preparation of the colon, you know, and describing the colon size, detecting and tell the endoscopist whether there are still something behind the fold that they have not seen. I mean, those things will make much easier to trust. And I think the trust and acceptance should be built step by step. And I would refrain from going into a very sophisticated and high-risk decision-making process as the first step.
Okay, thanks very much. I think Joseph, very good advice. And for young people working on projects, what I'm hearing is safe, right? Simplicity, simple things, not sexy stuff, essentially, right? Not those kind of things that we would like, that says, you know, you're able to detect and diagnose and cure, you know, that kind of thing. So I think something simple, safe, and non-sexy.
It could be quite sexy. Yesterday, I go out to the exhibition.
Yeah.
Somebody take a picture of my retina and tell me whether I'm demented. No, I'm likely to become demented or not, all right? It's very interesting, it's very sexy, but it's no risk. I mean, even the prediction is wrong, I'm not going to suffer much, right? But I still think that we should not jump into very aggressive and invasive procedures so quickly.
Okay.
One thing I would add, though, is that there should be something actionable off of your prediction. Because if you just tell someone, you know, you're at high risk for dementia, what are you going to do about it? That's kind of like, you know, we have these genetic scoring for glaucoma, and you try to do some genetic testing, and there's like the highest quartile people have X% chance, but it doesn't really tell you about the conversion and what you would do with your life differently. So you don't want to study too much where you can't decide what to do with the outcome, because you need more longitudinal inputs, or you know, it's a complex situation where there's it's multifactorial. The more complexity there is, the less useful it is. It's better when it's like, you know, some post-op visit, take a picture of the eye. Do I need to come in or not? It's binary. Yeah, you should come in. That looks terrible. I mean, that kind of thing is way more valuable, I feel like. And the more we can find those points to apply the algorithm, you'll make a huge difference in the patient's life and the doctor's life.
Yeah, so thanks very much. I think, Robert, you touched on a very good point. A lot of things are also non-actionable. So you have scores. I mean, you know, I always go back to classic Framingham equation, right? We have always studied that. Everyone needs to add up all the scores, and, you know, there's a kind of like a 9 times 9 type of rows, and then you get some heat maps there, and everyone's supposed to add up the age, sex, and all those risk factors. Nobody does it, essentially, even though it's quite useful, essentially. You know, so the glaucoma score has a little bit of this kind of things, essentially.
It's just because it's an association. Like when we do all of these studies and look at these big datas, there's no real causality that we can easily tease out when the data is just finding something that happens to be associated statistically. And so that's a problem for our field, unless we can say causally, you do this, you get this, and therefore you should stop doing this. And a lot of things that we do at a systemic level is just, it's like we're getting older or we're all going to die someday. And so how much useful it is that you're going to get some kind of disease when you know, well, as I get older, that's true, right? Okay. I can't stop aging.
Yeah. So in other words, okay, something that, yes, that's very true. So maybe I go to Haotian again. Expand a little bit. I mean, you said next generation, right? You are kind of like a next generation, a new generation. There are a lot of new generations here. What would you advise someone here? They are medical student. Should they do? How would you see their career, Susie?
Okay. I think I share some thinking about the new technology for the new generation. Actually, when I'm still a student or very young, what I understanding about the technology is different from what I understand now. Everyone know that if you have a new idea, and from the idea to a new paper published, and from a published paper to a new really technology to be applied in the real world in hospital, is really totally different. And from an idea to the paper, it's not easy. But from the paper to the new technology is more difficult. And so I think for the new generation, you know why we are doing this clocks study, or we should do the medical bioengineering. What we learn about the medicine is really difficult enough, but we have to learn more about engineering, about algorithm, about the IT, computer, new technology. Why we should do this? Because actually what we aim to, the problem we aim to solve is really need a new technology. So I think the new generation should have many fields, knowledge, technology, and can combine them together. Then we can solve this new aim for what we are looking forward to. I think this is one of I'm understanding what we are trying to do better. This first, and the second is that I think for the new generation, actually it's not easy. I think there's a saying that each generation has different challenge. Although we will get older enough, but I think what we believe is the same. Is the whole world is progress positively, not negatively. I think this is what we believe. So I think the new technology for the, for example, for the large language model is developing so fast, and I think what we need to do is for the new generation to keep learning every day. It's more important than the older generation.
Okay, very good.
Okay.
I think a lot of good points from Professor Ling Haotian.
Actually, I want to add to that.
Yeah. Okay, Robert. Yeah.
Yeah,
please
I have
add on
advice
that.
for you, new generation. I think about this a lot.
Yeah.
You know, I'm in the Stanford area. Everyone wants to, do everything. Everything's exciting, shiny, and fancy. So they all want to be doctors. They all want to do AI companies. They all, want to do VC world, everything. The most important thing is actually to become a specialist. That is what my view is, because the AI world is covering generalism. It's like college level knowledge now. It's supposedly PhD level knowledge in the next, GPT-5. But it's still not very, very deep in certain areas. And doctors become very good at specific, whether it's a treatment or rare disease or something, and they have amassed more knowledge than what you can just amass maybe from reading everything on the internet. And that's kind of what AI is. It's just taking all of our group knowledge and putting it into one algorithm, but it doesn't have all the experiences of each individual specialized cases. And so if you want to be really good in medicine, you have to really specialize in something. And right now, because diagnostics is being, people feel it's like a threat to have AI do the diagnostic for them, all you need to do is the treatments, because the chance for embodied AI, which is the robotics field, where they're going to be programming robots to do what the humans do using AI techniques, is still like one generation behind. So there's one generation ahead right now that's like, recall knowledge, right? Recall knowledge is becoming more commoditized. You could see the algorithms can just search everything and recall it for you. But fixing things like doing your surgery, your glaucoma surgery, you're going to have an AI. There's no way AI is going to do that. Not going to be able to do a filtering surgery for a long time. So if you specialize and do things that are actionable and take treatments and you get really good at it, that's how you preserve the value in the system. So that's my advice.
Can I jump in to argue a little bit?
Okay, sure. I welcome it.
No, I think I agree with you partly, but there's a famous English saying that when you have a hammer, everything looks like a nail. All right. So if I'm a specialist, I'm a gastroenterologist. People come in to tell me they have chest pain. I think, oh, esophageal spasm, achalasia. All right. I would not think of the heart. I would not think of the lung. I would not think of the aorta. So if all the doctors that in the future we train are specialists, unless and until we get the baseline or the primary diagnosis, the family medicine part, very accurate, and they know exactly where this patient should be triaged to should see an ophthalmologist or should see a neuropsychiatrist or whatever. We have a little bit of risk that patients may be misdiagnosed because of the professional bias. On the other hand, I would just try to answer your question partly. I think future medical students, when we, in medical school, when we choose what kind of students can apply for medicine, we always say, oh, they must know biology, they must know chemistry. I think in the future, they must know mathematics quite well. If they don't have some idea about mathematics, they probably will be having a hard time to understand the data analytics and what is noise and what is, to learn some basic about AI and data analytics, I think mathematics becomes very important. And then the other group of people which I think should also be considered studying medicine is the social science people, the psychology people. Because while the machine is maybe taking care of a lot of the information and knowledge part, medicine is still a humanistic endeavor, if you like. All right. Then people who understand people and people interaction becomes very important. They will compensate for the very mechanistic part of AI medicine and make the doctor-patient relationship still something that is acceptable to the patients.
Okay, a lot to digest, so not obviously consensus statements. I'll summarize some of these large concepts and we can have a bit of debate, right? What I'm hearing from Haotian about young people, new generation, what you do, you need to know the technology, the engineering and the medicine. I think everyone has that kind of similar concepts. It's great for that, medical students. And if I've always said, if you're a medical student, not done engineering, please do it. If you're engineering, you're not done medicine, try for it, essentially, right? Because there are some graduate programs that take some of these medical students. So that's the first point. I think I'm hearing from Robert, which I also agree with, and I also agree with Joseph, so I don't know how I'm going to split it up. Maybe we would ask ChatGPT or something. In other words, what Robert is saying, concentrate on clinical specialty so you become quite unique in that area, which will take time, maybe impossible for AI to kind of replace or to catch up, essentially, right? In the glaucoma, on surgery and so forth, that's quite hard. So for people that takes this kind of approach, too early being generalists, you lose that thing because a lot of information and so forth, knowledge is replaced. So those of you who are thinking, I don't want to do a specialization or don't want to do residency, and some medical students now so hot about AI and technology, after medical school they said, let's jump into tech, right? I think Robert has a little bit of thoughts about it. In other words, you have to persist and be an ophthalmologist like Robert or gastroenterologist like Joseph. What I'm also hearing from Joseph, which is also another viewpoint, which I think is quite important, is we are now too subspecialized in the whole medical field. There's a whole famous kind of examples everywhere, right? Where someone goes in with chest pain, they've gone to see so many doctors until it's kind of like become you're unclear, right? All the subspecialty, and they get some very common disease that's maybe the general physician or the GP can pick up, but the subspecialty can't, because you go to see a chest pain, you do the heart, go to see gastroenterology, you do a scope, and nowhere. So that generalist approach is also quite useful. Again, maybe no right or wrong. I think I'm also picking up this whole idea that we need people in social science inside here. I don't know how many social scientists here. We have a lot of engineering people, right? We have a lot of doctors, the medical field, less from the social scientists, and that could be something we have to think a little bit about, because as we all know, behavioral science and psychology of people is so critical, whether it's this technology or other technology. So a lot to kind of digest as we move into the different areas. I'm going to move slightly in a different direction and not concentrate too much about people development, which we have given a lot of advice for young people to think about, but maybe go into models and business models and larger models, right? What are we going to do, right? Robert touched a little bit on this, and I hear it from Joseph. What do you think AI is going to do? Because the government wants to cut costs, the industry, like the insurance company, wants to make profits. Is there a dichotomy, and how do we get things together? I mean, from a cost savings government type big priority to an industry where we're going to make money in this whole AI. I don't know whether, Joseph, you want to share a little bit about this broad perspective. I mean, you touch on many of these points from the government, but what's your thoughts about industry here and so forth? Joseph, yeah.
I think you asked the wrong person for this question.
Okay, yeah.
I'm the kind of person who don't even know how to read my spreadsheets properly, and not to mention about business plan. But I do not think making money and providing good service are necessarily mutually exclusive. Because we have, in some area, that we can use technology to provide service to lots of people at a reasonable and affordable cost. But at certain area, eye surgery or cardiology and so on, sophisticated technology can do something that is better than human eyes and human hands, and therefore they can generate lots of revenue. So I think depends on which specialty we're talking about and which level of complexity we're talking about. We can perhaps satisfy both. But from the public healthcare point of view, from the policymakers' point of view, it is important to make AI technology affordable and equitable. That means not only the wealthy people can enjoy it, but even elderly women staying alone, economically underprivileged, they can still benefit from technology. I think that is important from the healthcare authority to think about.
Okay, very good.
Okay, I think
yeah.
I can add something. Maybe I will maybe the right person to answer these questions or to talk about this, because as a president of a hospital, a big hospital, I think both is important to cut the cost, to improve the efficiency, or we said that the profits, I think, is important. I think the two things, there's no conflict about these two things. It cut costs, it can improve the efficiency. But for the AI technology, I think is still not at this stage to consider the profit or the cost. Everyone knows you should input a lot of time, a lot of money to develop the new technology. And so I think not every institute is proper to be developer of AI, especially for the hospital in China. And Tim, maybe you know that the government has now had this guidance. Not every hospital should do even research, because they need the people work is really different. And so I think for the AI technology at this stage, not just the hospital, but also the community government should work with things is not still not to the point to consider the cost or profits, but consider how to input more money to do these things. Still at this stage.
Okay, good, good. I think, yeah, you talk a little bit about that and the pressures of hospitals and so forth.
Yeah.
So maybe I'll stop here and now open this up to the floor so that we can also answer questions that people are interested in. Are there questions about any areas? We have a lot of very experienced experts here. Yeah. Jacqueline first, yeah, and then maybe others, please. Yeah, Jack. Wow, that's a very a big kind of question. So in other words, what keeps our three guests here awake at night? AI projects that you're thinking about, and you wake up or you think about it essentially. Maybe Joseph, what's your high-level thought? I mean, you have a lot of statements yesterday from your lecture, but what would be like high critical that we need to do? Yeah.
Well, I think AI projects should be designed in such a way that we don't need to wake up at night.
Yeah.
Right. Things to be done by the machine and taken care of even when we are not there. But I really hope to see more clinical trial, properly designed clinical trial that come up with robust data and evidence that it is not just a toy, it is something that change the outcome of the patient. And also make the hospital beds more available and so on and so forth. Because I can see a lot of studies that are producing data which is just, okay, this score is better than that score. And so what does that mean? Does it mean that the patients survive better? Does it mean that they can come out of the hospital earlier? That is what I care about. So we need more this kind of study.
Okay, very good. So that's what keep Joseph not awake at night. Hopefully, you don't have to think about it because of that. Haotian, what keeps you up?
I agree with Joseph, but I think what is more important at this stage is to the project to connect our AI algorithm into the traditional system of the hospital. You have mentioned that if we just do experiment in the computer or just validation with some chosen data, it is hard to be used in the real clinic. And what I think we are facing the problem is that the traditional information system in most of the hospital is not good enough to connect with the AI algorithm into the real clinical application. And so I think the most important one to put all the technology to the real world is to the connection, how to connect each algorithm into the system.
Okay, I'm going to get back to you because you're in charge of the biggest eye hospital in Asia, right? If I'm not mistaken, and the biggest one.
Okay.
So you are the president of the hospital, so why can't you put that technology? I'll come back to you. But that keeps you up awake at night, I'm hearing. Robert, what keeps you up awake at night in beautiful California?
Well, I think AI could be used in bad ways. For example, for collecting so much data and doing analysis, like let's say, I recorded your every phaco and I, automated segment how long you take to do each step of the phaco. And then I see, oh, this group of people do it way better than you do it. You shouldn't be doing that anymore because you're losing money for the hospital. So there are things that could happen through the analytics that would have effects that would, already eroding autonomy, the decision making, the sort of doctors are just stamping things as opposed to actually being the one who makes the final decision. So I worry that if the pendulum swings too far on the co-pilot issue, that we would, lose out to actually being one of the best parts of the job is sort of, making the final decision and owning up to the outcome. So we wouldn't want to just say, well, the data is better, so we're always just going to go with what the AI says. And I know everyone fights this all the time, but when you talking about money and you start talking about, executing things that it's more than just that one individual, then the individual's, goals can be lost. Because AI should just be deployed where we need automated, repetitive tasks that the human doesn't really want to do, because you can save a lot of time doing things with automation, and the AI data feeds it, and we don't have to manually do those things. So why not focus on that instead of focusing on, high-end diagnosis making and all the things that we publish on? Because there's a lot of other inefficiencies in the healthcare system, bureaucratic stuff. Give a scribe to every doctor, virtual scribe. This is very popular now because it's cheap to do the, listening to the patient-doctor conversation and charting it straight away into the record. That's like a really good use case because that's supposed to, unload the burden on the doctor who has to, type, or they don't bring enough revenue to have a human do it. So now you can do it virtually because, we have humans do it when the doctor sees a lot of patients, but then when the doctor sees very few patients, they can't afford to hire that person, then give them the AI version. I think these are the win-win scenarios. So we have to think about the win-win scenarios of the deployment of the AI, so that way it doesn't hurt us in certain ways. And the one last point about the AI, the human touch and humans are more empathetic. There's a lot of papers out there that show that the AI is actually preferred. They can seem more empathetic in terms of its language, its output, and you see this like movies about humans dating robots and loving the robots better than the fallible humans because they're imperfect, and AI can act perfectly in all situations. So there is something to be said about like how do we maintain that aspect of our care and not always looking at the AI as the ultimate gold standard. So it's okay to be imperfect, I feel like, but since this AI era is trying to achieve perfection, you're like, oh, I want the 100% sensitivity specific, that same aspect of everything else in medicine will potentially be a downside to using AI.
Okay, a lot of very provocative but very important thoughts. You become too hard on this road. I think Joseph mentioned it a little bit. Then you find us all lost in this whole maze. About going back to those keeps you awake at night in Silicon Valley. So that's like. Can we open it up to other questions? We had, Scott, yeah.
Actually, very simple questions. So I would like to ask, what do you think the role of AI can play in medical education, either specialists or generalists?
Okay, very nice question because we have an expert here, Joseph. Medical education, I think you thought a lot about it. And Scott's question is, how would AI be incorporated or used or taught or transform medical education? And you've obviously thought a little bit about this, yeah.
I thought a lot, but I don't know what is the best way of doing it because we are still feeling the stone crossing the river. Ideally, we should have a system that can tailor the progress of education according to the need and the strength and the weakness of the student. Okay, so right now, like in a class of 200 people, we give the same curriculum, same case studies, ask same question in the exam, and so on. And then they pass, they go to the next year. But more and more educationists believe that we should teach people according to their strengths. And some may go faster, and some need slower, but perhaps even not to learn this part, but to learn the other part. So if we have medical students from year one, and by collecting all the information, the process of learning, how many times they need to look at the video before they can actually grasp the concept of heart failure, for example, then we may perhaps start to triage them to, okay, this should be a physician because his hand is very clumsy. This should be a surgeon because they are very skillful in this, but they don't memorize things very well. I'm sorry, I'm not saying that's a surgeon, but I mean, if we can use this kind of information to personalize training, maybe we can explore the talents and utilize the talents better. That's ideal, but whether it is doable or not, I don't know.
I think quite a very new and quite important concept, and you know some people have written this before. It's called precision medical education, right? Like precision medicine, precision medical education. So what Joseph is saying maybe has many different models, right? Do you need everyone to be trained in Hong Kong will be 6 years in CUHK or Hong Kong U? Some Chinese universities 8 years, and then after that you need, if you're in UK, you need 8 years of residency training. US is shorter, right? And no one knows which is longer and shorter, but everyone goes through the same 15 years training, essentially, at the moment, right? To be a specialist and so forth. Is there something that Joseph is saying, either you shorten it or you tailor it? And of course, not everyone can be a surgeon or a physician. Do we know how? We have interviews and so forth. Could this help? So I think that whole aspects of not just medical education, but AI in education, I think the universities are exploring it quite a lot about this, but I think in medical, much less. So I think we should think a little bit about this. Ming Guang, you want to add something? Yeah.
Follow-up question to Joseph mentioned. As a dean of medical school, I think talking about AI is easy, but now we need to convert it from talking to doing. So can I just ask a very straightforward question? Do you agree to use the AI as like an unbiased assessor, for example, for your Islamic examination, or because at PolyU at the moment we're adopting the AI system for assessing the scoring of PhD candidates because it takes too much time and there's also a lot of bias. So do you believe in the short 20-year future when the medicine is going to use this new the AI enhanced assessment?
I believe that in medicine, in the curriculum, there are different stages and different aspects. There are times that they need to know some basic knowledge, all right? Krebs cycle, fatty acid, or physiology, and so on. But there are other stages that they need to learn more about communication skills, which is a totally different thing. All right, and then there are times that they need to know how to suture the wound and you know, make a proper incision on the something. I mean, I do not envisage in a very recent future that we can, you know, personalize it so quickly to tailor the education to different groups of people as yet. And it is dangerous to, you know, be too early to make a decision on. So I'm contradicting myself a little bit. On one hand, I want to see how technology can facilitate learning, teaching and learning, so that the learning process become easier and less painful, all right, by doing different things on different people. But I do not want to see very early on in year one, this student is considered not suitable to be surgeon, has to be a psychiatrist because he just talked. All right, I don't want to do that so early. So I must admit my ignorance in this area, how to, you know, strike a balance between this.
That use case sounds scary, to try to use AI to judge if a student is passing or not, because that means old biased data will actually affect the outcome. It's kind of like using who to interview on a job. You got tons of candidates and then they send in all their resumes and they try to screen the resume, and there's like basic embedded bias about gender or race or all kinds of things. That's true, it's true. But that's why we
this
try
is a
to.
very interesting topic. I mean, we can ask a few others, but let's, yeah, because let's go into Ming Guang here, right? Because let's say we already know in the past, when you have MCQ, you're going to get physical people to market, right? And MCQ now, of course, is automated computer. You fill the score, it reads it, and that's 100% accurate, right? So you don't have. So why can't paragraphs be written? I mean, we've all gone through teachers that say you're 5 out of 10. You say, that's not correct. Why am I 5 out of 10? Right? Another teacher could give me 8 out of 10. So shouldn't that paragraph of an answer that you give go through AI, biased or not, but at least it's equitably biased against everybody, right? You know what I mean? If you send it to a class. I mean, has anyone even thought about this thing? I mean, Robert, I mean, you say that's bias, but at least it's fair, right? It's the same direction. What do you think?
Well, it is true that making decisions using human decision making already has bias, that we know of that. But if you want to automate the bias, you can automate it, with AI, right? Because you're using our existing biases and just applying it at mass scale when you apply it through an algorithm, whether that's like deciding your credit score or deciding admission to college, or did you pass that PhD thesis exam? Everything, there's certain bias there. So giving up the control to the machine to say, I'm just going to do that because I don't have time, and I'm not going to try to strive for fairness and equity. I would prefer the method where the human still has a chance to try to debate it and strive for better outcome than just, well, it's more efficient this way. So
okay. So let me maybe we have a little bit of thinking or poll from the audience, and I'll switch it because not all of us are taking PhD and so forth. Let's say you send all papers to journals, and sometimes it comes back bad reviews and you think it's biased. Would you rather have it being open that every review of this journal is an AI scored, whatever that bias is, or you rather it be a subjective scoring, whether it's Ming Guang or Haotian or Robert? What will your view? Who is more for a standardized, quick assessment? You submit it in, it tells you the score, in other words, roughly whether it's going to be accepted next day. Anyone on that? Yeah, they don't want to get to Ming Guang who might kill the review, you see? And who would rather have it to be 3 weeks, 4 weeks, 6 weeks? Some of our papers now is 2, 3, 4 months, delayed by people like Ming Guang and Haotian, essentially. Right? Who would you rather have? Who would rather have them assessing, Ming Guang and Haotian assessing? So Carol has good friends with Haotian and Ming Guang. Okay, so anyway, it's not clear, but this is the thing that could happen, right? I'm sure some innovative journals now would do this.
No, but if you automate it, you're going to get the same output all the time because people will change their way of writing. It's kind of like the Scientific American paper that said that everyone uses certain more words now because they all put it through ChatGPT for their paper. And so then that format is always going to get accepted. So you're only going to self-reinforce a certain kind of output if you give it up to the algorithm.
Okay, good.
I certainly think that humans are more biased than AI in many sense.
Yeah.
All right, as an examiner, okay, I was examiner of MRCP when examiner can do everything to torture the students and make fun out of it and so on, all right? Then it changed to PACES, which everything is very clearly spelled out. If he put the stethoscope here, got 1 point. If he put it there, no point. I mean, so boring, right? So we like to, make it a little bit more exciting. So human can be much more biased than AI. But on the other hand, there are something that is very subtle that you may not be able to pick up by just a hard physical science. For example, I might fail a student because I think he's very rude to the patient. And how to assess rudeness by AI, all right, it's not correct or incorrect diagnosis. It's not whether the procedure is done properly. It's something that I may not able to explain why I think he is very rude. All right, the attitude is bad, and I think he should be failed because of that. So it's not an easy question. Yeah. But by and large, I still think that AI, if can be made in such a way that it take into account of more of the important parameters, that it should be less biased than human.
Okay, I want to add one more point to bias. In addition to bias, I think it's more important to the fair of the different people. And Joseph said that the education, AI can help to precision medical education. And I think not just AI can strengthen the strengths of different people, but I think more important is the strength, the weakness of different people. For example, the surgery, we know that for the ophthalmologist, if your hand is not stable enough, it can it's hard to be a good surgeon in ophthalmology. But with surgical robot, it can strengthen the weakness of this. So I think more important is to strengthen AI is to strengthen the weakness of different people. It will be more fair to different people.
Okay. So there's a lot more that maybe really AI technology can go into this whole idea of training, education. I mean, again, we've thought about it, but not as many people have gone into medical education. The medical education or education for that matter is a whole particular group of, you can say academic and professors, maybe traditional and so forth, right? Technology, go into clinical care research and so forth. But this seems like many things can happen here, selecting people, assessment, or at least assisting assessment, but of course some area that Joseph mentioned, you can't fully do it essentially. But
it's like knowing again the downstream need. What is your unmet need in medical education? Are you having a problem assessing people? Are you having a problem teaching people? Like if you look at Khanmigo, which is Khan Academy, they have an AI bot that can teach math. And math has right or wrong, and it can assume someone of any background anywhere around the world and get them up to a stage that they want to get to. That's kind of like a win-win scenario because there's not the subjectivity there in that situation. And so they apply this so that people who don't have access to resources get access to a resource. And that's like a good use case. So you have to think about what is the negative outcome of the use case of deploying it? What are the positives? Because yes, sometimes it's to help the weakness, sometimes it's to enhance the expertise already, to make the strong people stronger. It depends on your goal and what are you accepting in the current state versus what do you wish to be in the future state. And in that area you apply. Like if nobody has time to teach the books and you have a good online resource that is, deploying the lecture plus the quiz questions, and it's pretty fair because these are not biased. These things don't, it's like, facts, like physical facts property, right? There's not going to be a debate there. Then you can apply AI to that. It's okay.
Yeah.
Right?
Yeah, I think what I'm also knowing, again, similar to Joseph, we are designing all this curriculum, right? It's a lot of poor quality, lack of resources, not enough money, and that's in well-resourced universities like Tsinghua, NTU and so forth. There are many, many places I can tell you there's almost nothing, right? First, they don't even need enough there needs to be a third medical school here, right? Do you need that actually? Jeff Hinton said, should you stop training radiologists, right? That was his words, our Nobel Prize winner. Should you stop training doctors? Do you need so many doctors? What's your thoughts about that? That's the same kind of concepts. You could make better use of the doctors that you have doing less of the task because a lot of the tasks could be done by AI. Would that be?
One thing that's happening in the US is that primary care is being converted into virtual primary care with AI first pass, kind of like a screen. Like let's say you have nurse practitioners or physician assistants, and they need some support also because you have a lack of actual primary care generalists because they don't train enough and most of them are specialists. So then you fill that need with something that, if people can agree on what's a minimum level consensus, it's an okay use even if it has some imperfections. So it just depends on the context of what you're competing as the alternative. If you go into a city that has like no ophthalmologists at all, then any version is much better, right? That's why people deploy autonomous things where there's no alternative. and then they're easy on the ethical debate side. So you kind of look at it from that angle. What's the current status quo? Where do you want to go? And does it make sense to fit the AI version because there's no alternative?
Okay, very good. I mean, I think there are probably a lot of this kind of example. I mean, from a global perspective, right? Globally, it's not Hong Kong, it's not China, Singapore. I mean, it's a lot of lack in the whole area, not just the healthcare side. The education side is which is why they started MOOC and all this kind of things. Any questions about things? Yeah, this young girl first, and then yeah. Yeah.
Can somebody pass a mic over there?
Yeah, come. Where do you?
Just follow yours.
Yeah, yeah.
This is Shu Yizhang, a PhD student from the CUHK, and I have a question for Professor Song. We all know that deep learning area move fast, but clinical trial is very important, but it's very time consuming. It could be happen when a clinical trial for older version deep learning model is done, and a newer and more updated deep learning model is coming out. What should we do? Do we need to keep conducting clinical trial for updating deep learning model, or if the clinical trial also already show that the older version can have acceptable performance, we just leave the updated deep learning model alone? I would like to have your comment. Thank you.
I don't think we need clinical trial for each and every model from each and every manufacturer for the same class of tools that we are applying. But we will need a properly designed clinical trial with very clearly stated primary and secondary outcomes and statistical power and so on to show that this kind of AI tool, all right, is actually better than the traditional way of making a diagnosis of glaucoma, for example. Well, I mean, even look at the drug trials. We don't need to test each and every corticosteroids or, I mean, every drugs, right? There are so many in the same class. I do not think we need to do large-scale phase 3 trials for every drugs for that purpose. But at least there is some, and that would prove the concept. And as you say, AI tools can be evolving every day. Every month we have a new AI colonoscopy technology. So we don't need to follow that, chasing after the newest technology.
Okay, very good. So I think that's also a quite important thing. I think we just frankly don't even have enough clinical trials on classes of things, diagnostics, predictive screening, and so forth. So I think we probably will be quite good to do that, and then maybe you don't need an updated version. Dr. Chu, yeah.
I have a question for the panel. So AI can solve some problems, at least to some degree. Do you think in the future, AI can identify problems? Because problem solving and problem identifying is a big difference. If so, what are your thoughts on making the reality, for example, in medicine?
I think I can share some viewpoint for these great questions. Yeah, that's the question Sui had asked the RCT, the clinical trial for the traditional medical medicine technology. But for the AI technology, I think the new question the AI identifies that is still suitable for the new technology to use the old way to validate. I think it's very important to think this way. And another thing I want to add is that last question, Tim has asked the choice. For example, the Hong Kong's need to more medical school to train doctors or new AI technology for screening or to the new health service. I think actually, for the new step, is no choice. For example, in China, many province or many situations, no choice. It just can use the new technology to solve the problem. And so the new problem will appear when the new technology come. That's my think about this.
So there are many places really there's nothing, as Robert said, right? Any technology is better than no technology because there really is nothing for many places, particularly in China and many parts of the world. So that's obvious.
But there's also like many times where we have too many people, like our administration is too bloated. And we got all these people checking quality control metrics. Why do you need to have a person do that? Like what if you used AI to check to see if your hand washing is done and you don't need a person to be checking it all the time? And so there are ways to try to identify problems that are happening that could be impactful, on some metric. That's why you have to know what the metrics that you're measuring. Are you trying to measure like you're discharging the patients too early and they get back to the hospital too quickly? Are you measuring like, bed ulcer sores or something? So there's traditional metrics that we need to measure that actually automated algorithms, computer vision, all kinds of things could probably do it very well, right? They have track cameras, the patients are turned enough to make sure they don't get bed sores, and these are high value things. And so ambient AI technologies, especially when the cost of sensors go down, IoT stuff is getting used, we've got some privacy rules, these are the stuff that people are working on.
Yeah,
I think your question is actually a very good and very deep one. And that is whether AI can ask question instead of answering question. I'm not expert in this, but I've learned that Turing once said, when AI have consciousness, it is the time that it will become difficult to control, become autonomous. And consciousness can mean a lot of things, but one of them is that they can start to think and reflect on what they're doing and ask questions that, is it really necessary? Is it really good or bad? And so on. So I like to see science fiction movies. You remember a long time ago, I don't know whether you were born or not, there's a movie called Odyssey 2001, all right? And the computer is called HAL, and it starts to talk to the person. I mean, it's amazing. This movie is in 1980 something, all right? And they have already imagined that in the future, the computer can talk to the person, and he's asking, is asking some quite philosophical question. And then many years later, there's a Steven Spielberg movie called AI, where there's a small kid which was a robot with AI, all right, because the parent thought they lost the child, and then they brought this robot home. And the robot has emotion, and he then starts to ask existential questions like, am I your child, or are you my mother? Can you become my real mother? And this sort of question, I think in the future is possible. I believe in science fiction. Everything that they imagine someday may actually be possible. And that is the time when they start to have consciousness. I hope I won't live that long to see that happening.
I think there's another movie that I like to always kind of like, whenever I teach, sometimes I show this. It's called Ex Machina. I don't know whether you've seen it. Ex Machina. It's a really nice movie because it's also, it's like all the science fiction, a bit of a thriller, right? And in that movie, to summarize it, there's an AI lady robot. Of course, pretty, but you know it's an AI because it's a lot of machines behind. But it's pretty and was fitted with the characteristics of the person that she's supposed to interact with, because the person that developed it took the data of the young man based on his internet, what he likes to see and read and eat and so forth, and therefore made an AI that would fit exactly what this is the dream woman, right? You know, and to fit that. And the inventor of it said, I can tell you, this is the AI, you can see, just turn around, it's behind is metal, right? And the challenge was, knowing it's AI, the young boy still fell in love with the AI, knowing it's an AI, right? Not that, you know, it's a fake, right? I mean, you could peel off the skin, maybe you didn't know that, you thought that you were food. But knowing it and you're food, and that goes back to Robert's point, right? Maybe that is a better companion for this guy than any other human on, you know, the 6 billion people that they are trying to find along this place. So that's quite scary, essentially, right? You could imagine that's already happening because the images, you know, the way we search our internet and so forth, whatever is coming out of YouTube is based on your search history. After a while, it's mostly tailored to your needs. And after a while, the person is interacting with you, first voice, second robot, and third, you know, the person is going to deliver your food to you, the Wai Mai person is going to be tailored exactly to you. So how do we address this kind of, you know, future, essentially? Maybe Joseph and I, hopefully we won't live until that long. Robert.
Yeah, the AI can know you better than you know yourself, because if you feed it all of its data, it can find patterns that you wouldn't recognize. But I don't think it could be self-conscious, like to want to destroy the world independently without being programmed. So that's a big debate, you know, for AGI and all of this. A lot of people talk about this, but I think with the compute that we give it and with the data that we could give it, we can definitely make it appear that way, because that actually the ceiling hasn't been reached. So if you just give it more compute and more data, it can still perform better. That's what all the experts say. It's just that the soul of the human, or essence of becoming a human, is not codable that way in the way we design the architecture of the current, you know, transformer network. So you would have to talk with like Jan LeCun and like all these guys, and they're trying to come up with new architectures to behave differently. And the machines would need to have more sensors, more inputs. Because right now its input is just whatever we give it, but in essence it would have one day have to have all the sensors and independently take in the real world data, and maybe then, you know, have more self-learning.
Okay, we have time for maybe 1 or 2 more, and then we're going to close. Yeah, Tony first, and then this young girl. Yeah.
Hi, it's a fireside chat, right? So I put a bit fire on the last couple of questions. So I represent the young generation of researchers, early career, and I also have my wonderful collaborators like Shidan Li and Yvette Wong. So everyone is moving to big model, and I find APTOS is very competitive. Everyone's doing large scale language models and the foundation models, and it's very resource dependent. So that's not very friendly to the young generation people, because we do not have resources like you do, because in Haotian you own a hospital, right? And Joseph, I was in the FEVS last week, Singapore. You gave a talk, I supported young people, and Tien-Yin mentioned about, yeah, there's lots of professors in China, they're getting lots of data, right? But all the resources are in your hands, not in young people's hands. So we are facing difficulties, not getting resources, not getting funding.
The dean doesn't have all the resources, trust me.
Yeah, I'm not on the hospital. Actually responsible for the development of the hospital.
Okay. Yeah. So yes, the question is very direct. So in this era, foundation model, language model, how young generation people like us, we don't have many resources, how are we going to develop our career and be successful like all of you? Okay.
Very good. Haotian first, and then Joseph.
Okay. That's really a question that put everyone on fire. Yeah. And actually, I think how to understand what is the resources. I think for the nowadays, the resources for everyone is the time and energy, but not money or a big office. It's really. So for the young people, I think you have many resources on your own hand. You can control your time. I cannot control my time. I have many work. So actually, I'm out of resources, really. I'm just in charge of the development of a large hospital, but that's not myself. I'm not on the hospital. So for the young people, you should understand that I think if you can get older and more understand about really what resources, it's really the time and your interest and your energy. It's your really not money, not big office, not GPU, CPU. I think all these things can be solved. You can own all everything, but you cannot make your time come back for yourself.
Very good. I
Okay.
think you answered. So a lot of options for the young people. You see, not Haotian, no time anymore, essentially, right? Joseph?
Okay.
I totally agree with you. I think you have more resources than I do because you are young. That means you have time
Yeah.
and you have imagination. The older you become, the less imaginative, thinking out of the box. So look at Jack Ma, look at Bill Gates. I mean, they all come from the garage and, I mean, where was the resources, right? But you have an idea which just suddenly works, and then you become the center of the world. So I think you guys have more resources than we do. Yeah.
Okay, so keep it up, essentially. Keep your fire. Okay, this young lady, yeah.
Yeah, thank you so much for the sharing. I think it was very inspiring. Especially, I like the concept of precision medical training. I think that was a very brilliant concept. So I'm also a freshman PhD student, and as I was hearing all the sharing, I thought of one of the research ethic module that I have been taking this past semester. So in this module, I was assigned to analyze this case study where it's saying that this pharmaceutical company was going through this drug development process, and then they deploy an AI model for this process. And then suddenly they noticed that this AI model detected this very dangerous toxic chemicals during the process. And then the case wanted us to analyze, so what should this company do? Because my initial thought was that this company should definitely terminate this exploration because these toxic chemicals would have would maybe cause like dangerous consequences. For example, like it might make so maybe some dangerous consequences would happen, like there would be some bombs being developed based on these toxic chemicals. So, but then our instructors say the company cannot really stop because they are looking for profits. You cannot just terminate the whole development discovery process. So I wonder if for this situation, what would you recommend the company to do? Because I'm not sure, since AI is very new and very fast developing, I kind of have a sense that AI is like a Mustang. It's beautiful, but it's wild. It runs free. So I'm not sure as human, how should we really better work with this technology? And I wonder if there's any like maturing constitutions or law enforcement where we can seek for help if we run into this kind of situation.
It's very complicated. Robert, complicated answer. Give us.
That's an interesting question. I haven't heard this before. I guess this must be in some kind of ethics class or something, huh? Yeah, I mean, AI is being used to solve crazy problems like protein folding problems, and it gets, something that other people can't do, and so it behooves us to, study it and check the outcomes. And if there's something that looks negative, you have to verify. Everything has to be double checked, fact checked. Everything, you got to try to understand why. Because if in AI it's mostly like some statistical association, because that's what it's built on, it's mathematically statistical, you have to know if there's some intervening causal factor in there that is producing the result that you're assuming. Because there's, like anything we study in medicine, if A then B, there could be C, D, E's inside there that you just don't know, and you're only looking at the final output. So obviously if things are harmful, then people are going to shut it down because they don't want to cause harm, right? That's one of our first tenets. So I can see why it became some kind of question for you to work on as a problem, because it doesn't have straightforward answers. But that's a lot of things that we work on in life. I think for the AI, you don't have to do it by yourself, although you can if you want by doing open source. because there's resources for that. That's why there's a competitive commercial side and open source side. What you really need to do is you associate with a person who has data sets and or compute resources, and they don't have enough time to use it all. That's like mentorship. That's how every student has gotten ahead from beginning of time. You just associate with the people who are solving problems that you're interested in, who have the tasks that they can't complete, that you have the time and energy to complete. So you associate yourself with someone who is slightly ahead of you, but is doing the things that you want to be doing, because that's in reality, and you go and meet them and talk to them and do it at like meetings like this, where you can just come up to somebody who's very famous right here, these two famous doctors, and talk to them. I mean, that is not an opportunity you always get, so that's what I recommend.
Okay, very good. Anything?
I don't know how to answer your question very specific on your case of finding something toxic coming from a drug that you're developing, because I don't know all the story behind it, all right? I don't know the details. But just to suggest a few principles. Number one, medicine is a science which has to be conservative and should be conservative, because you may do harm and take people's life, all right? So to be conservative is reasonable. Number two, guideline and law are different, okay? You can set some guidelines, but it may not have to be law, and you have to strike a balance between innovation and breakthroughs. Yeah, I mean safety and innovation. Okay, so if you do something very straight, then you stifle innovation, but you are very safe. But if you if you do that, but if you allow a lot of innovation, inevitably you will make some mistakes and could have disaster. So I simply have no straight answer to your question, but there are several principles that you have to think about. Yeah.
Okay, I think it's a very good answer, and we're going to close this. Maybe I just have one point to add. I think we can wait for guidelines and laws and regulations and policies, and many countries and places and universities and hospitals cannot keep up with those kind of guidelines. And therefore, quite important for the community, right, people here, to set values. Values means ethical principles, principles for physicians, do no harm, right? Keep going back to the principles. So whenever you have anything else you are doing, you teach that to the young people, you teach that to the medical student, then you don't need a rules-based, you can't do this, you can't do that, because the guidelines does not say that. Just keep values in our core, right? Because it's going to change along the way. After large language models, there'll be other hot thing, right? And then what are you going to do? You have a new set of guidelines, you can't keep it up. So let's maintain our human value system, in part values, ethics, preserving the, our freedom as humans. All those are quite important things, whether it is senior people like us here, younger people. You aspire to that, then you'll be all right for all these things. So I'm going to once again thank maybe our three panelists for very enlightening. Obviously, there are more questions and answers. I'm going to finalize this by asking for maybe a show of hands, because it's. Do you think that how many things that AI, the future, is number one, very good and bright, or is it number two, scary and we are worried? Number one first. Very good and bright, hands. Okay, good. And then scary and worrying for the future. So less, but there is some, essentially. So
This is a biased population you are.
Okay. All right. So I think, once again, I'd like to thank the panelists. We have to move on. But just to, again, just let you know, I mean, the next APOIS, APTOS will be in Japan. The next APOIS is in Beijing, and we'll have many more of these kinds of sessions and talks in the next meeting, which is here, as well as in the APTOS meeting. Thank you very much for everyone coming here. Thank you.